So basically, with the clinical examination, we're trying to document, measure, and evaluate a number of things. Okay, these include facial aspects, so the patient's facial profile, the patient's facial symmetry, and things of that nature. Oral health as well. Jaw and occlusal relationship, so how the jaws are and their relationship to one another, as well as then with the teeth in terms of the occlusal relationship. Are they malaligned teeth? Are they any malpositioned teeth? And things of that nature. And then as well as functional characteristics of the jaw, so how the jaws are, how they relate to one another, as well as checking for any neuromuscular patterns, such as with your habits of tongue thrust, swallowing, digit sucking, and biting, and things of that nature. And then from there, with our diagnostic records, so they talk about photographs. So I've already discussed the type of photographs that we take in orthodontics, but they're basically useful for patient identification. That's one. Treatment planning, just to decide like what's our course of treatment, essentially. Case presentation, especially if maybe in academia, where now you're discussing a patient with your other colleagues to get like a second and third opinion, and so on. Case documentation, just to follow up and just to monitor the progress of the patient, as well as with patient education. So you're discussing with the patient, you're telling them how things are currently, what we need to improve upon, as well as what are we going to do going forward. So then from there, there's some extra oral photographs that you guys will see. So that would be our patient in frontal as well as profile view over there. And then there's some pictures of some intraoral photographs, like the type that we take. So the frontal view and occlusion, as well as the maxillary and the right buccal view. But normally with the buccal views, we take both the left and the right hand side. And then when we take pictures of the jaws, we take off the maxillary arch as well as the mandibular arch. So then they discuss radiographs. So we have our Ceph radiograph, which is an extraoral radiograph. So we basically use it to evaluate anatomic basis for malocclusion, the skull, bones, as well as the soft tissue. Like I told you guys, once the x-ray comes out, we then normally put, either, depends on the practice, some people have software on their computers that actually make or place the landmarks for them. And then in our cases where we do not have that digital software, we actually have to go in and draw, rather trace on top of the x-ray to actually find the anatomic basis and landmarks that we are looking for. Then from there, so tracing or computerized drawing, using a series of points to compute a means of mathematical descriptions and measurements of the status of the skull. So basically, once you actually found the landmarks, we then find like the degrees or values that we can then interpret to actually understand quite a number of things, how the patient is growing, the direction of growth, like any and all other discrepancies that are happening at a skeletal level. Yes. And then, okay, so that's an example of Ceph and the landmarks that we'll discuss at a later stage. And then diagnostic models, also known as study costs, basically used for diagnosis as well as aiding in the treatment plan, and then can also be used for case presentations, as I had highlighted before. So here, guys, they talk about the goal for orthognathic or orthodontic treatment, These are very important. So these are the Andrew 6 keys to normal occlusion. So basically, when we get in and try and correct a discrepancy with a patient, we are trying to get them as close to these 6 keys of normal occlusion as humanly possible. So one, the teeth must be, the molars must be in a class 1 molar relationship. I've already discussed that with the angles classification. And then from there, key 2 is proper crown angulation. So basically the crown, especially of your incisors, must not be either too retrusive or retroclined, as well as protrusive or proclined. So we're just trying to find a proper crown angulation. And then from there, proper crown inclination, like I said, protrusiveness as well as proclination, and retrusiveness and retroclination, then we do not want to have. And then from there, key number 4 is no rotation. So any rotations we try to actually, any rotated teeth we try to actually bring back to their original position. And position essentially, yes. And then from there, key number 5, no spaces. So any and all spaces we need to close up. Like in my case where I have a diastema, you see, some would also argue that that is a space that could need or does need correction. And then from there, key number 6 is a flat to slight curve of speed. Yeah. So then the next slide talks about clinical evaluation. So the requirements for normal occlusion. So jaw and occlusal function must be in harmony. We must have structural balance, so everything must be in its appropriate space. And then from there, aesthetic harmony. So basically the patient must actually look aesthetic. So that's essentially what we require from a normal occlusion, and this as well, ladies and gentlemen, is very important. Then we did discuss already the 3 types of orthodontics. So it's preventative, interceptive, as well as fixed. Now, so the next slide just basically talks about preventative orthodontics. Like I had highlighted before, we are basically here trying to make sure that the conditions in the mouth are basically stable to not cause a malocclusion. Okay, so this would include like the control of decay. So any teeth that are carious will have to obviously be restored or extracted, but ideally restored, because carious teeth actually result in a loss of space in the oral cavity. So that's what we're actually trying to avoid by restoring teeth, especially in children or children of a primary or mixed dentition. That's essentially what we're trying to achieve. And then from there, space maintainer. So if, for example, a tooth has undergone, or a child has undergone trauma, or the teeth are so badly decayed that we cannot restore, obviously we have to put space maintainers. So space maintainers are, I could say, appliances that actually try to maintain a space after a tooth has been extracted. And then from there, correction of habits. So now if we've identified like a patient, let's say over the age of 4, you're still thumb or digit sucking, we try to address that and get that patient off that habit, because it can lead to malocclusion, things of that nature. Or if we see like a pathological tongue thrust that is detrimental to the patient's oral cavity, we also try to correct that. This also includes the early detection of genetic and congenital abnormalities. So now if we see that the patient's oral cavity as well as medical conditions give us reason to suspect an underlying condition, then we also try to take the appropriate steps and refer to appropriate practitioners, so that we can get to the root cause of what is causing the dental condition or oral manifestation that we are finding. And then from there, supervision of natural exfoliation. So sometimes it's actually a bit too early to intercept, so we actually try to make sure that what is already there in our chair that is manifesting with the patient, we try to actually maintain before we actually take any corrective steps. So that's essentially the type of things that we do with preventative orthodontics. So they're just trying to show you space maintainers. Very, very, very important, so as to not lose space and therefore cause impactions or rotations or crowding or things of that nature, or even affect the molar relationships according to Angles classification. So here's some pictures of patients where they've basically placed space maintainers in the form of band and loops, as well as distal shoes. So distal shoes basically an extension of a band, and then it just has like a little shoe-like structure, if I can put it that way, just to maintain the shoe. It's very hard to clean this specific appliance, so sometimes that's why we normally even go for band and loops as opposed to distal shoes. Yeah, so they just showing you more space maintainers as well as its retention. And then from there, they're talking about submerged primary molars. So basically, submerged primary molars are teeth that are basically ankylosed. So when a tooth is basically ankylosed, it's I could say trapped within bone, so therefore it cannot erupt into the oral cavity. So it basically becomes over retained, and then it has undergone infra-occlusion, so it is basically below the occlusion line. So this is also problematic, because normally extracting such teeth tends to be a bit more difficult. And then from there, teeth that are below the line of occlusion then almost always cause over eruption of the opposing teeth in the opposite arc. So such teeth have to be identified and dealt with accordingly. From there on, we discuss interceptive orthodontics, favorite. So here, basically, we are seeing that a problem is developing, and then we try to actually intercept that problem before it actually becomes more aggravated or even worse as it already is. So this would include the early removal of primary teeth, so be it they're too carious, or sometimes they are over retained, or sometimes we need to extract them just to create more space for other teeth in the oral cavity. And then from there, correction of cross bites. Like I told you, we have appliances that can just help teeth jump the bite and actually sit in their correct positioning. Then from there, correction of jaw discrepancies. We do them at this stage. So basically, we try to maybe minimize or inhibit or restrict the growth of a jaw, be it the maxilla or the mandible, so that it can actually give the opposite jaw a chance to catch up with the position that it is currently in. But here it's like a bit awkward to actually do that, because normally interceptive patients are still growing patients. So sometimes you inhibit that growth, then the moment you take out that appliance, the patient still carries on growing as they should, because they're within their growing stage, And then from there, extractions to prevent overcrowding. We normally do this by extracting primary teeth, obviously, just to make more space or facilitate the eruption of the permanent teeth. Yeah, so basically from there, they talk about headgear. So headgears are an orthodontic device that is used to control the growth as well as tooth movement. So like I said, with headgears, ladies and gentlemen, it is used to control growth as well as tooth movement. So basically they can actually be used to bring about tooth movement, particularly with the distalization of molars if necessary. They can also be used to basically control the growth of the patient's either jaws, essentially. So basically it is, I could say, a strap that either goes behind the patient's head or behind their neck. So normally when it goes to the head, we call it occipital headgear. When it goes to the back of the neck, it is then called a cervical headgear. So we basically use it either normally to restrict growth vertically or to restrict growth horizontally. So that is essentially what it does, and then it is then attached to some bands that are normally placed on the maxillary sixes. So like I'm saying, by it then obviously restricting growth or minimizing growth, then it just gives the opposite or the opposing arch just a chance to actually grow and correct the skeletal discrepancy if necessary. Okay, so essentially that's how it works, and then the patient puts it on for X amount of hours every day. We normally like doing it after school, because obviously you're going to look weird walking around with the headgear around school. So then from there, a headgear has a head bow. So this head bow, like I said, either at the back of the neck, occipitally or cervically, can be used to distalize or move the maxillary molar distally and create more room in the arc. I've already said that. And then from there, the traction device then applies extra oral force to achieve the desired treatment results. I think that's what I basically said. So then here's a slide that shows you the 4 types of traction. These 4, how can I put this? Let's just stick to the occipital and cervical ones, because now, yeah, the other 2 are not used so frequently anymore. Yeah. So ladies and gentlemen, with our lip bumpers, they're giving you an example of an interceptive orthodontic appliances. Lip bumpers basically, I could say, are myofunctional appliances. So these are appliances that act on both the muscular aspects of a patient's face as well as the dental aspects to bring about changes dentally. So here they've given you guys an example of a lip bumper. So a lip bumper is basically an appliance that we put either in the maxillary or mandibular arches, but we're usually in the mandibular arch. So it has like a bit of acrylic, as you guys can see on the slide. So it acts basically to remove the forces of your soft tissue, being your lip as well as, this anterior space. So basically your lip, from acting on those teeth, especially if you have crowding or the patient has crowding. So by doing that, by alleviating those forces, it actually gives the teeth a chance to procline, get into a more proclined position. By doing that, we therefore then correct the crowding discrepancy that we find in a patient's mouth. So like they're saying, it can be used effectively in severe crowding, as well as the mesial shift of the lower molars, because it is placed on said lower molars anyway. And then from there, the other example they gave you guys are expansion screws, lav expansion screws. So basically, These are, I could say, appliances that we basically, they get fabricated, they come back with a little key, then we instruct the patient how many times to turn, over which days, and then basically from there it just acts to open up the arc. Either, it depends on the type of screw, so it can either expand the arc anteriorly or transversely, so on the left and the right hand side. So this is done mainly to create space, and then sometimes to correct cross bites, especially if they are skeletally and even posterior cross bites. That's essentially what they are used for. So those are some of the examples that are provided in these slides. And then we have corrective orthodontics. So corrective orthodontics, these are problems that we cannot treat with interception, and they require braces and treatment over a long period of time. So these would be like severe crowding, severe skeletal discrepancies, maybe if the patient is not complying with interceptive appliances, because normally you can take them in and out of the oral cavity, then we place them onto something corrective and permanent, so that it's actually stuck in their mouth. Especially, like, let's say, like our thumb suckers, who despite that an appliance has been placed, they still placed during the interceptive stage, they're still placing they digit in there. Then we can go for a more permanent example. So even with like rotations, or a tooth has changed or has a dramatic change in angulation, those are some of the things that we can actually correct using corrective orthodontics. So like I said, these are fixed appliances, normally almost always braces, and then from there even removable appliances can be used, but this is mainly for correction and maintenance. So by maintenance, normally, ladies and gentlemen, is if the patient, let's say, has been on braces for 2 years, we're happy with the result, then we actually take off the braces. We then put an appliance, like a removable appliance, just to retain the work that we've already done in the patient's mouth, as well as then orthognathic surgery. So these are normally in class 3 skeletal class 3 patients. So maybe the mandible has grown far longer or more than the maxilla. Then we actually will then have to operate on the patient to bring that back and correct that skeletal discrepancy. So those are some of the things that are done with corrective orthodontics.